and welcome to today's webinar, Substance Use Screening Tools for Adolescents. I'm Tracy McPherson, and I will be your moderator for today's event. This webinar is produced in partnership with the Adolescent SBIRT Project, NORC at the University of Chicago, and the BIG Initiative, and sponsored by the Conrad N. Hilton Foundation. Today's webinar is one of a series on using SBIRT to talk to adolescents about substance use. So make sure you check out all of these important topics. In addition to today's webinar on substance use screening tools for adolescents, the series will also include Brief Intervention for Adolescents, Part 1, Brief Negotiated Interview Using MI Strategies, and Brief Intervention for Adolescents, Part 2, Brief Negotiated Interview Using MI and CBT Strategies, as well as discussing options and referring adolescents to treatment. You can check out all of the webinars at sbirt.webs.com/webinars and download the flyer. If you are following along in your Learner's Guide to Adolescent SBIRT, the education presented in this session complements Module 1, Why Use SBIRT with Adolescents, which provides a foundation for understanding the rationale for using SBIRT with youth, and Module 2 on Screening Tools for Adolescents and Young Adults. If you'd like to order an electronic copy or hard copy of the Learner's Guide, you can visit sbirt.webs.com/curriculum. For your future reference, you can download the PowerPoint slides and other resources on our website at sbirt.webs.com/substance-screening-tools. After this webinar concludes, you'll receive a follow-up email from us. It will contain instructions for watching the on-demand recording, obtaining a free certificate of attendance, and completing a short evaluation survey. We would greatly appreciate you completing this short survey. Our aim is to bring you high-quality professional education, and this survey really helps us to assess how we're doing and to better understand your needs. If you wish to ask a question, you can do so by typing into the questions pane in your GoToWebinar control panel on your computer or your mobile device. Someone from our staff will respond to you as soon as possible after this webinar concludes. Now it's my pleasure to introduce our presenters. Our first presenter today is Dr. Ken Winters. And Dr. Winters is a senior scientist at the Oregon Research Institute and an adjunct faculty in the Department of Psychology at the University of Minnesota, which is where he's retired from as a professor in the Department of Psychiatry, and where he founded and directed the Center for Adolescent Substance Abuse Research for 25 years. Dr. Winters has received numerous research grants from the National Institutes of Health and various foundations, and he's published over 125 peer-reviewed articles over the last 30 years. He recently co-edited the second edition of the Clinical Manual of Adolescent Addictive Disorders, published by the American Psychiatric Association. And he's on the editorial boards of the Journal of Substance Abuse Treatment, the Journal of Child and Adolescent Substance Abuse, and the Psychology of Addictive Behaviors. Dr. Winters received his BA from the University of Minnesota and a PhD in clinical psychology from the State University of New York at Stony Brook. It's my pleasure to introduce our second presenter today. Our second presenter is Dr. Brett Harris, and Dr. Harris is the Director of Public Health Initiatives at the Suicide Prevention Office of the New York State Office of Mental Health, where she oversees initiatives related to schools, colleges and universities, and communities, and the relationship between substance use and suicide. She works with large health systems and community providers to integrate suicide-safer care into multiple service settings. And in addition, Dr. Harris is a clinical assistant professor at the University at Albany School of Public Health, where she's designing a course in suicide prevention and collaborating on alcohol and drug prevention and early intervention projects. Dr. Harris has previously developed, she's implemented, and she's evaluated alcohol and drug SBIRT projects with the New York State Office of Alcoholism and Substance Abuse Services, and she serves on the board of directors of the New York State Public Health Association. She received her Doctor and Master of Public Health from the University at Albany and her Bachelor of Science from Cornell University. So it's my pleasure to welcome both Dr. Winters and Dr. Harris, and I'm going to turn it over to Dr. Winters to get us started. Welcome.
And thank you, Tracy. I speak for Brett and myself in welcoming all of you to this webinar. And I want to send a big appreciation to Tracy and her colleague, Misty, at NORC for developing and organizing this resource. There are two main sections to today's webinar. I'm going to kick us off by talking about the basics of the SBIRT model and why it's a promising approach for use with young people. And then we'll move into more specifics about screening tools. So youth is going to be defined really as adolescents and young adults. The standard definition for adolescent age group would be 12 to 17, young adults 18 to 21. The resources we will be talking about are very relevant to this broad definition of youth, with one caveat. Keep in mind that some screening tools were normed just on adolescents, so when used with older youth, you want to be careful, see what the authors say about use as applied to that age group, and make sure the content is relevant. A good definition of SBIRT is provided by SAMHSA, a comprehensive, integrated public health approach to the delivery of early intervention and treatment services for persons with substance use disorders, as well as those who are at risk for developing these disorders. So through this practice, practitioners work to identify substance use through the screening process that increases the risk for all kinds of health problems. And the SBIRT practice then quickly allows the practitioner to move into a behavior change or brief intervention strategies, typically revolving around the use of motivational interviewing. And the final component includes the need often to refer your client for additional treatment or services. More specific aims of SBIRT are the following. It increases early identification of adolescents and young adults at risk for substance use problems, builds awareness and education in those clients on the risks associated with their use, motivates those young people to reduce their unhealthy or risky use patterns and adopt more healthy behavior habits, motivates individuals to seek help and increase access to care for those at risk for a substance use disorder or may even have a current problem, and links adolescents and young adults to more intensive services when needed, and along those lines fosters the support of a continuum of care. So SBIRT has these three components: screening, brief intervention, referral to treatment. As noted, we'll be focusing on the screening component. Just some things about the screening process. Keep in mind that it's not something that's definitive. You're doing a rough screen with hopefully an accurate tool. Fortunately, there's several psychometrically sound screening tools for adolescents, which we will be reviewing. Several of them, the good ones, are listed at the bottom here. Screening by self-report, either self-administered or an interview, does make sense, since in theory the teenager is the most knowledgeable person about their own substance use. Obviously, you might not get full disclosure or accurate self-report, but it makes sense to try this method. As will be discussed in future webinars, the brief intervention is an approach that aims to help somebody either get ready to change or to make changes if they feel so inclined. Brief interventions can vary from a brief conversation that lasts only a few minutes or can be extended to include a handful of sessions. As already noted, brief intervention typically revolves around the use of motivational interviewing techniques. And the last arm of the SBIRT model is referral to treatment or additional services with hopefully a follow-up component. So often you're going to see a need for additional services for your adolescent client. This could be something where involve a warm handoff. In your clinic or setting, perhaps you as the therapist could add on more sessions, or you may have to refer for specialized services in the community. Follow-up means care management and coordination according to protocols and services to help support the teenager as they move towards a healthier behavior path. Next up, some reasons why SBIRT makes sense for adolescents. I think it's a very friendly clinical model. Hopefully you'll see how that plays out throughout the description of both the screening and the other components. Many professionals with diverse training and experiences can learn SBIRT skills, and I think it can be easily implemented in many types of health-serving settings. I often think of the Swiss Army knife as the metaphor for an SBIRT. There is now a growing research body that supports the effectiveness of SBIRT. There's a large adult literature and a growing body of evidence with respect to adolescents. I think the most promising data is with respect to reducing or halting alcohol use, but there's already some indications that it can have positive impacts with respect to marijuana use. Several organizations and agencies have endorsed SBIRT. These include National Institute of Health, World Health Organization, U.S. Surgeon General, and U.S. Preventive Services Task Force, and the American Academy of Pediatrics. And it's being mandated in some instances, which is a plus, I think, because it is now achieving status as an essential service. For the next few slides, I'm going to focus on some adolescent substance use issues. As already noted, the SBIRT model seeks to expand the reach of bringing clinical services to youngsters who have already started to use substances. And as many of you know, substance use is still fairly common among teenagers. With one of the more recent national surveys, these numbers here reflect what 12th graders were reporting in terms of last 30-day prevalence use: alcohol, marijuana, vaping, any illicit substance. They are still used at provocatively high rates. Cigarette rate is quite low, which is promising. These two charts focus on alcohol. It is still the most commonly used substance among teenagers. One good trend over the last 5 years across all ages or grades that were assessed with Monitoring the Future survey, 8th, 10th, and 12th graders, there's been a steady decline in past year drinking and recent binge drinking. However, there is one negative trend regarding alcohol, and that is daily drinking, unfortunately, has increased among 12th graders. These charts indicate two important trends. They just focus on 12th graders and the most recent survey in the United States. So one trend is that any type of illicit drug use in the past year among 12th graders has held steady over recent years. But within these data points are some details. Non-marijuana illicit drug use is down, but marijuana use is level or has not gone down. So progress with reducing illicit drug use among youth is facing some barriers because of marijuana's popularity. More details about marijuana use. These two charts compare data from 2017, 2018, and 2019 for the three grade groups that are measured by Monitoring the Future survey, 8th, 10th, and 12th graders. On the left is the chart showing the trend of daily use of marijuana. Among 12th graders, daily use has held relatively steady over the three-year time period. However, among 8th and 12th graders, there's been a significant increase in daily use. On the right is the chart showing the trend of past year use by grade. And this shows that the younger grades are reporting a slight increase in past year use of marijuana, whereas there's a decline in past year use among 12th graders. So the gap is closing between 10th and 12th graders with respect to marijuana use. Both the daily and the any use in the past year do show some uncomfortable trends when it comes to our younger students. This chart is important for the green line. For the time being, ignore the bars at the bottom, but the green line focuses on the percent of high schoolers that indicate that they believe using marijuana is a great risk to one's health. So the major trend, unfortunately, is that proportionally more youth are not viewing the use of marijuana as harmful. So consider the two endpoints. The first number in 2007 indicated 55% perceived marijuana use as a great risk to one's health. But in 2019, that has dropped down to 27%. Last focus of our substance use patterns is on nicotine. This slide shows the most recent Monitoring the Future data related to nicotine use. First, look at the chart on the right. This slide shows the continued decline in past month cigarette smoking, so very positive there. But on the left, we're seeing a comparison of daily use of smoking and of vaping. You can see that daily cigarette use is quite low. In fact, the rates for the 12th graders of 2.4% is a significant decline from the previous year. But you can see that the prevalence rate of daily nicotine vaping is significantly higher than use of cigarettes. Monitoring the Future is going to continue to measure this use of nicotine through vaping, and we'll see how this plays out in future years. Briefly, some attention to the potential health problems due to substance use during adolescence. On this slide, there are three major health domains summarized with respect to the negative impact of early substance use. Negative effects on adolescent brain development, increased risk for developing a substance use disorder, and increased likelihood of experiencing several psychosocial and health problems. Keep in mind that isolating the unique effects of early substance use on health outcomes is a complicated research question. It can be difficult to separate out possible confounding and pre-existing variables that may also be influencing health outcomes. A little more about the intersection of onset of substance use during the youth years and risk for future substance use disorder. As this slide indicates, young people who use alcohol or drugs before age 15 are 5 times more likely to develop a substance use disorder. This increased likelihood also varies just based on how early or later before age 15 use begins. If use begins of alcohol before age 12, the likelihood factor is much greater than if you wait until 15. And the reverse is true as well. If a person waits until 21 before starting to use alcohol, the risk for developing an alcohol problem later in life is negligible. And of course, that speaks to the importance of screening young people and screening for even the commonly used substances, and trying to get a young person to think about either stopping use or delaying it. So 2 final points about the premise of the SBIRT model. One is that unfortunately screening is not done all that commonly. It's an example of a missed opportunity. For example, a survey of health professionals indicated that only about 30 to 40% of pediatricians and only about 15 to 25% of family practitioners routinely asked questions to adolescent patients about their alcohol use. And these percentages are much lower when we're talking about younger adolescents. Then there's also the issue of unmet treatment need. Based on national household survey data, it is estimated that only about 12% of youth who need treatment receive it. So SBIRT is a model that really tries to reverse these 2 trends that are unfortunately not promoting health and well-being of young people. So now I'm going to turn over to my colleague, Brett Harris, who will move us into section 2 of this webinar, and we'll get into screening tools.
Thank you, Ken, and thank you to NORC for inviting Ken and me to participate in this webinar. So there are a lot of different screening tools available, and in my experience, I used to work and kind of really implementing SBIRT statewide in New York State, and we were often asked what screening tools do we use, and we kind of found that the fewer choices, the better, because there are definitely some screening tools that are recommended specifically for SBIRT because they are standardized and validated, but they're also quick screeners that can be used in settings outside of substance use disorder treatment where screening is most appropriate, and which are fast-paced, and usually providers don't have enough time to deliver anything that takes more than an additional few minutes. So here we have provided a few different screening tools that we do recommend for use and some information about them. And we're going to be going over the tools that are highlighted in orange, and so that's the CRAFFT+N 2.1, the S2BI, the APA NIDA Modified ASSIST Levels 1 and 2, the BSTAD, and the PHQ 2, 3, and 9A, and the C-SSRS. So as you see, a number of these tools are specifically to substance use, alcohol, and drugs, and some add in nicotine. And then later on in the presentation, we're going to start talking about depression and suicide risk screens, which are often comorbid with substance use, and my background in really addressing that intersection between substance use, depression, and suicide will kind of guide that discussion near the end of this presentation. All right, so the American Academy of Pediatrics provides guidelines really for screening and brief intervention for substance use in pediatric settings and in primary care, and they recommend the use of the CRAFFT screening tool and provide some guidance. So they have 4 different categories: low risk abstinence. So this is someone who is reporting no use and not having ridden in a car with a driver who had been using any substances. Then there is driving risk, because it is, of course, a risk to either be under the influence and driving or riding in in a car with someone who has been using, even if you yourself have not been using. There is moderate risk. That's for adolescents who have begun using substances. That's a CRAFT score of 1. And then high risk are adolescents who use substances and are scoring a 2 or above on the CRAFT. So that's usually deemed a positive score, a 2 or above. but it's still some risk if an adolescent is scoring 1, which really doesn't say that an adolescent should not have any form of intervention if scoring under a 2. So we will get into that a little bit later. Another way to assess risk is through the algorithm that the National Institute on Alcohol Abuse and Alcoholism, or NIAAA, provides. And this is based on the number of days of drinking in the past year, as well as the age of the individual. So as you can see, the younger the adolescent, the more risk there is if that adolescent is drinking. So for any young person 11 or under, any days in the past year is high risk. And then it breaks it down into moderate risk and lower risk categories based on the algorithm of matching up the days with the adolescent's age. And then the next question becomes, what is a drink? Because you will be asking an adolescent to talk about the number of drinks that they've had in a certain time period. Of course, there's all different types of alcohol, the mixed drinks. It's sometimes hard for an adolescent to define, or actually really anyone to answer that question, how many drinks. So it's very important to kind of show a diagram that looks like this to someone that you're working with, to have them accurately identify the number of drinks you can best assess need. And often, when SBIRT is implemented, this information, and actually this exact picture, is often laminated or available, say, on a tablet screen and shown to the patient to help them identify accurately the number of drinks they've had in a certain time period. So, asking about substance use, regardless of the tool, it can be difficult because don't forget that though we talk about substance use, or maybe marijuana or alcohol use becoming, or even vaping becoming prevalent among youth, it's even alcohol use is illegal, so it might be very difficult. And of course, it's a sensitive issue, and they know that they can get in trouble for it. It might be difficult for them to admit or that they're using, or wanted to discuss it. So it can be a tough and awkward, and kind of a little nerve wracking at the beginning when you're starting trying to do this procedure. So I think that it's important to have practice and maybe memorize the tool and get it so it's conversational, so the adolescent is at ease. And then it's also important to introduce a conversation about substance use, and not necessarily just beginning with the questions, but have a good transition between having the adolescent come in and then just starting to administer the tool. So screening can be administered in a number of different ways, and it really depends on the setting that you're working in, the workflow, who is delivering what part of the intervention, because there's often a pre-screen that goes along with the screen, the patient population you're working with, and just the way that your practice is set up. So the screening can be written, or it can be oral, it can be self-administered, or it can be given by a staff member or a practitioner. And often when they're self-administered, after they're completed, the adolescent will meet with the practitioner, who will then review the screening score. So self-administration with an adolescent may save time and be most efficient. It can be part of the check-in process. And you can complete that in the waiting room or exam room. We know there's always some downtime when someone is waiting to get to be seen by a doctor or nurse practitioner. It also, the self-administration often creates a sense of privacy as well. There's no bias towards wanting to please the person who's asking you the questions. It's also important to inform parent or caregiver present that the adolescent should complete the form on their own. And it's also important that the practitioner, to, as I said, to review and verify the self-administered responses during the visit. So, of course, the self-administration, particularly for adolescents, is often, it's underscored that this does help to elicit more accurate responses due to the sensitive nature of the topic. And now, we do know that adolescents are really, actually a lot of us, but specifically adolescents, like using technology that's available, digital communication. As we all know, on different social media platforms, they really quite freely self-disclose on those. So we believe, that electronic screening could be ideal because of the privacy and kind of uh, its ability to elicit uh, accurate and honest responses. So it's also when there's adolescents may be responding to screening questions in a language other than English. So it might have a translated tool is important, and it might be easiest to actually have that tool available for self-administration. But we can't forget that reading comprehension or literacy plays in. And just kind of give a little example. Some of the work that I had done in the past was implementing SBIRT across sexual health clinics in New York City. And in New York City, we have a very diverse population, many languages spoken, and we we're really trying to figure out how to best implement this protocol. And it was a very high volume clinic too, so we were finding, just really looking at our process data, that we were pre-screening self-administered in the waiting room, and then doing a full screen with the practitioner while being seen, and face to face. And we realized that a large proportion of the people who were pre-screening positive never got a full screen because they were coming in and out of the clinic before they could be seen. So we thought, let's try administering the full screen in the waiting room as well, self-administered, but then found that a lot of some of the questions were left blank, and we found it was because of reading comprehension, and that the questions weren't being understood. So we had to weigh the pros and the cons, and decided to continue doing the pre-screen self-administered and then the full screen in person, face-to-face. So the ICD-10 codes are used for billing for screening. So we have general screening codes as well as specific codes for alcohol, drug, and tobacco screening and counseling. So you can see these codes here. These are the codes that are defined not by NORC, but by the billing and Medicare, Medicaid, and so we have encounter screening, unspecified, alcohol abuse counseling and surveillance of alcoholic, counseling for family member of alcoholic, drug abuse counseling and surveillance of drug abuser, counseling for family member of drug abuser, and tobacco abuse counseling. So we always recommend going to your billing department and figuring out which is the best way to bill for screening and brief intervention services, because we know that there are other services being provided and also being billed for. So it's best to determine that ahead of time. Starting the conversation with an adolescent is very important, because we know it's often that they are coming in for something else, not related to substance use. And it's important to really ease into the conversation. So we're providing a few examples here for you. One is, in order to help you get the correct services, I would like to ask you some questions about your health that I ask all of my clients' patients. These questions will help me to get to know you and provide you with the services you need. Is that okay? So you see that you're telling them that this is something that's routinely done. So it's not like pointing them out and being like, I think that that you might be exhibiting problem substance use. And it's also important that you ask for permission. Another example is, as a way To help me to get to know you, I would like to ask you some questions that I ask all of my clients' patients. Is that okay? So if the adolescent questions this, you have a couple of examples of responses here. You could say, I ask everyone about their alcohol, tobacco, marijuana, opioids, and other substances. It helps me better understand your concerns and the things that may come up in any work we do together. The information you tell me is confidential. I will not disclose your answers to your parent. So as you can see, the confidentiality issue is very important. So that to stress that is really helpful, useful. So after the adolescent consents, you could say, now I'm going to ask you some questions about your use of various substances during the past year. So the research has shown that adolescents who are aware of confidentiality are more willing to seek health care compared to their peers who might not have the same awareness. So, we always, in implementing a program, particularly with adolescents that are talking about sensitive issues, to stress the importance of confidentiality because this could be done in a primary care practice. It could also be done in a school setting. So, not only would adolescents be worried that their parents might find out, but they could also be worried that their teacher or their principal will find out, and sometimes even worried that their friends might find out. So state laws do govern minor patients' right to confidentiality of information shared with healthcare providers about substance use. But states vary as to whether or not a minor can confidentially receive substance use treatment services. So you should explain the full policy regarding disclosure of sensitive issues directly to the adolescent at the beginning. And it's if willing, to the adolescent, it can be helpful to explain the policy with the adolescent and the parent or guardian at the same time to make sure you are aware of your state policy and that you have that knowledge and information to share at the beginning of the visit. So, some examples of conveying confidentiality, you could say, everything you tell me will be confidential unless I hear that you're harming yourself or someone else, or you tell me you've been a victim of abuse. I will keep our conversation about your substance use between us unless you agree to include your parent. Do you have any questions for me about confidentiality and its limits? All right, so once we introduce the idea of the screening, then it's time to administer the screening. So the first screening we're going to use is the CRAFFT+N 2.1. And this is the most recent version of the CRAFT that brings in questions about, or brings in at the beginning questions about nicotine use. This is the most popular substance use screening tool for adolescents between the ages of 12 and 26. It is recommended, as I said earlier, by the American Academy of Pediatrics Committee on Substance Abuse. And this committee has published some documents that provides guidance on its use and how to interpret the screening score and go into a brief intervention. So this screen is designed to ask age-appropriate questions, and it includes information about alcohol, drugs, and nicotine use, and screens for lifetime alcohol and drug use disorders simultaneously. So a lot of the tools, if you are aware, um, sometimes there's a tool for alcohol and there's a tool for drug use, and this is convenient in that it has both of them in the same tool, and it's also a short, easy to use screen. The original CRAFT was released in 2002, and then there's been a few updates. So the version 2.0 was updated in 2016, version 2.1 in 2018, and then version plus N 2.1 came shortly after that. So the CRAFT developers are really encouraging practitioners and organizations to at least use the 2.0, if not higher, because of improved psychometrics and how the tools gather information about a fuller range of substances, which actually leads to more accurate screening of adolescents. So one of the things that they had updated between the original version and version 2.0 is that they asked not a yes or no question about has there been any use in the pre-screening portion, but on how many days. So if it's 0 days, the adolescent says 0 days. But previously, they would have to say, yes, I was using alcohol, or yes, I was using drugs. And it was found that they would be less likely to provide an open, honest, accurate response doing that because of issues related to being judged. There was less judgment involved if they could just give a number of days, more factual. So all versions of the CRAFFT can be administered via interview or self-administered, of course, either electronically or in paper. So Part A, there are two parts of the CRAFFT. Part A is really determining if the adolescent has used any alcohol, marijuana, or drugs in the past 12 months. And the plus N portion of this 2.1 includes tobacco and nicotine as well. And Part B asks about the adolescent's experiences with alcohol and drugs. So all of the changes in the CRAFFT since the original version have been to Part A, and they've been light modifications, while Part B has remained exactly the same. So I'm going to walk you through Part A of the CRAFFT+N 2.1, the most recent version of the CRAFFT, and it's asking about past 12-month use. So during the past 12 months, on how many days did you drink more than a few sips of beer, wine, or any drink containing alcohol? And you would put 0 if none. Use any marijuana, weed, oil, or hash by smoking, vaping, or in food, or synthetic marijuana like K2, spice. Use anything else to get high, like other illegal drugs, prescription or over-the-counter medications, and things that you sniff, huff, or vape. Or use any tobacco or nicotine products, for example, cigarettes, e-cigarettes, hookahs, or smokeless tobacco. So any days of use to those opening questions would then trigger all 6 CRAFFT questions to be asked. So that's Part B again. If the adolescent answers 0 to all of the opening frequency questions, only the car question of the CRAFFT is asked, and that's because an adolescent can still be riding in a car and with someone who has been using alcohol or drugs. The Part B questions, this is where the acronym CRAFFT comes in. You can see the highlighted words that align to that acronym. Have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? Do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? Do you ever use alcohol, drugs while you were yourself, alone? Do you ever forget things you did while using alcohol or drugs? Do your family or friends ever tell you that you should cut down on your drinking or drug use? Have you gotten into trouble when you were using alcohol or drugs? So just to go over the updates from the original to the different uh, new and improved CRAFTs. So Part A in the CRAFT 2.0, it's more clearly formatted and rephrased to offer more clarity and examples of contemporary products and methods of administration. And then, as I said, it is incorporating opening questions inquiring about the frequency of past 12-month use of alcohol and other substances rather than asking them yes or no questions. Again, because that yes or no kind of brings the fear of being judged. And asking about frequency is more just matter of fact and factual. New in the CRAFT 2.1, so really the only difference is the second question in Part A adds vaping as a method of administration for marijuana. It reintroduces smoking as a method of administration from the original CRAFT and includes oil as a type of marijuana product. So again, you can see that it's updating it so that it has the most recent form methods of administration. And new in the CRAFT+N 2.1, it adds that a full question in Part A about the frequency of tobacco or nicotine use in the past 12 months. Very important with the rise of the use of e-cigarettes among youth. Now, on to scoring, and the scoring is pretty simple and makes the tool easy to use. So Part A does not go into the score. It's really just used to indicate which parts of Part B are asked. So each yes answer to questions in Part B scores 1 point, and no answers score 0 points. And then you just tally the scores. And it does say here that a score of 0 to 1 can indicate that there are no problems. But it could also there could be, and as the American Academy of Pediatrics guides, that there could be low risk or moderate risk in that range. So it doesn't mean that no intervention is provided if there's a score of 0. It could really be beneficial to provide positive reinforcement and encourage the continued good behavior. And then also scoring a 1 to really highlight how use could impact the important parts of an adolescent's life, and even impact uh, their academics, hobbies, or personalities. A score of 2 or more can indicate that a more significant problem may exist and a brief intervention is indicated. So that score of, as we said earlier, of 2 and above is really what they call a positive, but it's not a hard and fast rule. All right, so I'd like to give this a try and give you an example of what it's like using the CRAFFT+N 2.1. So Ken and I are going to do a role play. Ken is going to be the adolescent, and I'm going to be the practitioner. So I'm just going to read you the scenario. 16-year-old high school junior was arrested for vandalism of school property when they were caught spray painting graffiti after school. Because this was their first offense, they were instructed to participate in a school-based diversion program for 1 year. During their first session in the program, they met with a practitioner who conducted a risk assessment to identify any behavioral health issues and to connect them to appropriate services. In order to identify risky substance use along a broader continuum, the school-based diversion program integrated the CRAFFT+N 2.1 screening questions into their risk assessment, replacing the assessment's standard substance use questions. So please, follow along, and if you'd like to score while we are doing this, that would be great. And you can, to yourselves, identify what kind of level of intervention would be provided following the screen. So, Ken, if you're ready, I'm going to get started. Hello, Ken.
Okay.
This is Brett.
All right.
How are you feeling today?
Okay, I guess, not too bad.
It sounds like you aren't feeling great, but not feeling too bad either. Is this correct?
Yeah, I guess so. I'm not here because I really want to be, but I'm here.
Well, as part of my role in this program, I'm going to ask you a few questions that I ask all my patients. Please be honest. I will keep your answers confidential. Is it okay if I ask you these questions? They won't take too long to complete, and you're stuck with me today anyway.
Wait, you're gonna share my answers with my parents?
No, everything you tell me today will be kept between us unless I feel that your safety or safety of others is at risk. If you think I may need to share anything with your parents, then I will always talk with you about it first.
Okay, as long as you talk to me first.
Yes, I will always talk with you about it first, and we would plan together exactly what I would share if I were to share anything with them.
Okay, I guess we can keep going.
During the past 12 months, on how many days did you drink more than a few sips of beer, wine, or any drink containing alcohol? Say 0 if none.
Past 12, that'd be 3 times or so, about 3.
During the past 12 months, on how many days did you use any marijuana, weed, oil, or hash by smoking, vaping, or in food, or synthetic marijuana like K2 or spice? Again, say 0 if none.
That's 0.
During the past 12 months, on how many days did you use anything else to get high, like other illegal drugs, prescription or over-the-counter medications, and things that you sniff, huff, or vape? Say 0 if none.
0. I've only done alcohol.
During the past 12 months, on how many days did you use any tobacco or nicotine products, For example, cigarettes, e-cigarettes, hookahs, or smokeless tobacco. Say 0 if none.
That's 0.
Thank you for sharing that information. Since you told me that you drank alcohol 3 times during the past year, I would like to ask you a few more questions about your alcohol use. Would that be all right?
Yeah.
Have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs?
Ever done that? Yeah. I mean, got to get around. Yeah.
Do you ever use alcohol to relax, feel better about yourself, or fit in?
Well, yes, I use it to relax. I like to drink once in a while. It helps me feel less anxious, at school at times, or even at parties.
Do you ever use alcohol while you are by yourself or alone?
No, that's not me. No.
Do you ever forget things you did while using alcohol?
No.
Do your family or friends ever tell you that you should cut down on your drinking?
No.
Have you ever gotten into trouble while you were using alcohol?
Well, that's the reason I'm here. So, this is one instance where that's true. Yes.
All right. Well, thank you, Ken, for acting as the adolescent. And so Ken scored a 3 on the CRAFFT, which is a positive screen. So the practitioner would then review the screening score with them and conduct a brief intervention with the goal of getting them to stop or cut down on their drinking. The practitioner should conduct an additional brief intervention to monitor behavior changes over the course of the adolescent's time in the diversion program. So to learn more about how to conduct the brief intervention, please catch the second or third webinars in the series. And now I'm going to hand it over to Ken to talk about the S2BI screening tool.
And thank you. Yes, so the next set of slides, we're going to focus on some additional screening tools. We picked these because we like them as we do the CRAFFT. They're solid, psychometrically sound, have been used with adolescents, and they fit our criteria of being brief, short, and accurate. The S2BI is a relatively new tool created by professionals at Boston's Children's Hospital. It begins with a set of questions to assess the frequency of substance use in the past year. And the categories are the typical ones that are abused by youth. Now, it has an interesting feature in that if the youth says there is no recent use of the more common substances used by adolescents, alcohol, nicotine, marijuana, then the interview stops asking about the other substance categories or classes. Now, this is an efficient procedure, and it's based on the fairly reliable finding that teenagers do not use the so-called harder substances if they haven't already used the so-called more common ones. So you pretty much would get a lot of no's if somebody has not used either marijuana, alcohol, or nicotine, and thus no need to spend time with that. So before the core questions of the S2BI are asked, the interview begins with something like this. The following questions will ask about your use, if any, of alcohol, tobacco, and other drugs. Please answer every question. By the way, I like the fact that it has the if any clause in there. I think that's important for teenagers to hear that you're just not always assuming that they're using. So here's the main structure of the instrument. You can see it has the 3 introductory questions, and you can see to the right are the response options: never, once or twice, monthly, or weekly. So it's not just a straightforward yes, no. And then there in the middle are the instructions to stop if you don't get any answer other than nevers, and you follow up with a little more detail with 4 additional questions. So it's not all the various substance use classes, but some of the important ones. And this just provides another way of summarizing how to use this screener. You've got the 3 intro questions. If never to all of them, you stop, but if you get anything but a never of the 3 initial, then you move on. And the instrument provides some guidance of when you should apply a brief intervention. You can see from this chart that essentially the idea is when the risk level is at the mild, moderate, or severe end of things, you definitely want to do a brief intervention that includes I think a rigorous application of motivational interviewing. If you get the once or twice type response to any of the substances, the recommendation is brief advice. Now that might be that 3 to 5 minute conversation that highlights for the youngster that it might be best to pull back or make sure not to use and create any health risks. Next up is the Modified ASSIST. So this was originally developed by NIDA and then was adjusted by the American Psychiatric Association. ASSIST stands for Alcohol, Smoking, and Substance Involvement Screening Test, normed on adolescents. It has 2 levels, and you can choose one or the other or use both because they vary. The first level is more about behavior problems that could be related to substance use or not. 21 general behavioral problem items are provided. These address the internalizing and externalizing problems often seen in clinic settings, as well as risk for suicidality. In addition, it has 4 follow-up items about substance use frequency, just a straightforward yes, no. So quite brief on the screening for substance use behavior and involvement. Level 2 version of the tool is very detailed about substance use. So it has 15 items, each item pertaining to a specific substance category or class, and answers are now based on a 5-point scale ranging from not at all to nearly every day. And the authors of this tool also provide some both scoring and interpretation guidelines. With level 1 results, the notion is a rating of mild on any of the item within a domain would likely lead to more detailed assessment. A mild rating would be a number 2 or higher on the 5-point scale, 0 being at the low end, never, or not at all a problem, and 5 being extremely problematic. Level 2, they recommend that you move forward with perhaps even a brief conversation, brief intervention, if you see more than a 0 on multiple substances. Now, they don't provide specific guidelines, so this is where clinical judgment comes into play. You can imagine that if you're getting only a 1, let's say, which means very little use on just nicotine, that might not suggest a brief intervention. But if you've got 1s and 2s on multiple substance categories, or got even a 1 on what we might call a very hard illicit drug, that surely would merit, I think, a clinical follow-up. And then the third tool to summarize is the BSTAD, and this stands for Brief Screener for Tobacco, Alcohol, and Other Drugs. This is also a relatively simple, straightforward, and psychometrically sound tool. It's a 2-tiered screening tool. The first set of questions asks about the adolescent's past year substance use, and then the second set asks about the friend's substance use. For the teenager's use, if there's any yeses, then more detail is asked. And what is assessed here is number of use days. So use days refers to any day in which the teenager used the drug even once. And then they're asked for 3 time frames of use days: last 30 days, last 90 days, and then even for a full year. You might wonder if this is really very accurate to have somebody recall how many days in the last 365 you use something, but it turns out it's reasonable at a screening level to get this kind of detail. So it does get some inquiry into many different drug categories. It's one reason I like this tool, because it appreciates that there's the common drugs used and abused by teenagers, but it also allows you to see what kind of use patterns and involvement there is across the other main drug categories. At the bottom here is the website where you can get the electronic version of this tool. It's the only version that's available. I'm not even sure it's simple to download it and turn it into a hard copy version, but putting it on an iPad and allowing both self-administration as well as in-person interview is very doable. And also the authors provide some guidance here of scoring and interpretation. So the notion is if the adolescent answers yes to any of the 3 initial questions, then you would follow up with the detail, including not only those 3 core drugs, alcohol, tobacco, and just other drugs, but then you get the details of what other drugs might be in that teenager's history. And then remember, this has the second level where you're asking about the teenager's peers and their use. That makes a lot of sense, because you may know peer use is an excellent predictor of a teenager's own use. The authors recommend that you, with younger teenagers, so essentially, let's say younger than 14, younger than 15, in that range, it's advisable to first ask the questions about their friends' use and then ask about their personal use. The thinking is this may put the teenager more at ease. You may get a teenager that says they don't use it all, but they have a lot of friends who use a lot of substances, and that would be a risk factor. I think you could focus your brief intervention just around making sure that if that is true, the person isn't using, but their friends use, but making sure that peer use is not creating a risk for the individual to start using. This slide shows you a summary of how to score and interpret the BSTAD. You can see that they provide different risk levels based on whether there's any use or not. I think it's pretty straightforward that brief intervention would be recommended if you have a score pattern that puts the teenager in the higher risk level. At the lower risk end of things, you perhaps could think about a brief conversation, particularly if that one day of use was a very hard, dangerous drug. So we're going to role play again. We're going to give the BSTAD some attention with help from my colleague Brett, who's going to role play along with me. This time I'll be the practitioner and Brett will role play the adolescent. So for this role play, Brett is going to be a 16-year-old adolescent girl, and I'll be the practitioner. We're meeting for the first time in person in an office-based setting. The appointment was initiated by Brett's parents after discovering in her closet a nicotine vape pen and several flavored cartridges. The parents want help in responding to the situation, so I'm administering the BSTAD verbally during a session that is already in progress. So, Brett, thank you for spending some time with me. Now we're going to move on to talk specifically about your use of substances. I ask all of my clients questions about their alcohol, tobacco, and drug use in the past year in order to achieve the best outcomes for them to plan ahead. This should only take a few minutes. Is it okay with you if I continue?
Sure, that's what we're all here for.
Great, great. I appreciate your willingness to work with me on this. So I'll start with, in the past year, have you smoked cigarettes or used other tobacco products?
Cigarettes are gross, and they make you smell. Vaping is much better because it's cleaner, and no one can smell it on you.
Okay, so vaping now is preferred than cigarettes, all right? So you don't smoke, but you vape nicotine and have done that in the past year. Is that right?
Yeah.
Okay, got it. I'm writing that down. We'll follow up a little later. So how about alcohol, though? In the past year, have you had more than a few sips of beer, wine, or any drinking type of container that had alcohol?
No, I don't like to drink.
All right. So you have not consumed any alcohol in the past year. Okay. So how about other drugs? Here's some specific questions. In the past year, have you sniffed or huffed anything, or taken illegal drugs like marijuana or cocaine, or taken prescription medications that were not prescribed for you, or maybe taken prescription or over-the-counter medications and took more than you were supposed to take?
No.
All right, very good. So let's go back. You mentioned earlier that you vape a nicotine pen. So now focus on the past 30 days. In these past 30 days, on how many of those days have you vaped a nicotine pen, at least on one occasion in a day?
I don't know. All of them, or maybe like 25 of them.
Okay. And so now let's extend it to the past 90 days. On how many among those 90 days have you vaped a nicotine pen?
Well, I really just picked it up about 2 months ago, so maybe like 50.
All right. And I'm going to expand one more time, even further out. So over the past year, on how many days have you vaped a nicotine pen?
Like 60 maybe?
Okay. About 60 over the past year. All right. Thank you. So you've been using nicotine almost all days in the past 2 months. Okay, I have that written down. So finally, let's switch over to your friends. Do you have friends who smoke cigarettes or used other tobacco products in the past year?
Yes, but just vaping. Everyone does it.
All right. And how about drinking? Do you have friends who drink beer, wine, or drink anything containing alcohol in the past year?
Yes.
Okay. And how about friends in the past year? Have they sniffed or huffed anything, or took illegal drugs like marijuana or cocaine, or took prescription medications that were not prescribed for them, or maybe took prescription or over-the-counter medications and took more than they were supposed to take?
Sure.
Okay. So you have some friends who fit that. Okay. So let's review what we found from the interview using the BSTAD, and thank you, Brett, for helping out. Brett exceeded the highest threshold for nicotine use. You can see that it was pretty heavy use in the past 30 days, and then for sure is even extended out to 90 days. Although it's relatively recent, she's regular pattern looks to be starting to emerge. So it would make sense, as the BSTAT would point you towards, to conduct a brief intervention on the nicotine use. And perhaps a referral to treatment is needed if after the intervention and you see that perhaps either more problems arise, or you might see that you're not making a lot of progress. More on how to implement a brief intervention with this kind of clinical picture will be provided in future webinars in this series. So I'm going to turn it back to Brett, who is going to talk about a screening for other risk factors.
Thank you, Ken. So we know how important it is to screen for risk factors for, or I would say, issues that are often connected with substance use. So we're going to go over depression and suicide risk. And so my background, as you may remember from the introduction, that I'm also, in addition to working on SBIRT for substance use, I'm also working on suicide prevention and really seeing how to incorporate suicide risk into the SBIRT model. And we know that depression and substance use and suicide risk are definitely interconnected. So I think it's really important that we discuss this topic and really fit it into this model. So, in addition to substances, the United States Preventive Services Task Force also recommends screening adolescents aged 12 to 18 for depression in clinical practices that, importantly, are equipped to perform or provide a referral for diagnosis, psychotherapy, and follow-up. So it's important to have a protocol in place, trained practitioners, or a referral process prior to implementing the screening. It's also really, I mean, it makes sense, but not only important, but it makes a lot of sense to ask about depression and substance use at the same time because they often occur together. Because adolescents, if feeling depressed, often can use substances to cope. Um, so we know that basically just integrating it's you'll see as the next few slides that there are just another brief questionnaire and a few brief questionnaires that can easily be incorporated. It won't take too much additional time into the screening process. So the first set of tools we're going to talk about it's really based on the PHQ-9, which is a commonly used screening tool for depression. So we'll go over the PHQ-9A, which is an adolescent adaptation to the 9, as well as the PHQ-2 and 3, which can serve as pre-screeners for the full PHQ-9. The PHQ stands for the Patient Health Questionnaire. It is very commonly used. It's short, brief, it's reliable, and it's validated for depression. So it is part of a larger module. It's self-administered, and it was first developed in 1999 for adults. But it has research has demonstrated that the 9 with the PHQ-9 and its applicability to adolescents. So the A version, the one for adolescents, is lightly modified. It's very close to the original PHQ-9 for adolescents ages 12 to 18. So the 9 questions only take about 2 to 3 minutes to complete, so it's perfect for busy practices. And it's available both in paper format as well as a clinical interview, and it can be self-administered as well as done face-to-face with a provider. So the first 2 questions of the PHQ-2 are commonly referred to as the PHQ-9 are called the PHQ-2. As I was saying before, it can be used as a pre-screening tool to really figure out whether the full 9 should be asked. This saves a lot of time in busy practices by asking questions that aren't necessarily relevant to someone that is not experiencing depression. The PHQ-3 is the first 2 questions plus the last question, that 9th question, which inquires about suicide risk. So it's actually pretty, I would say it's critical to ask that last question just about that suicide risk, so it would trigger another, if indicated that there are some thoughts about suicide, that a further screener be administered to find out some more about what's going on to further assess the risk. So the PHQ 3 and the PHQ-2. So if they are positive screens, you would go on, pre-screens, you would go on to the full PHQ-9A in this case. So I'm going to briefly go over the 2 pre-screening versions, the PHQ-2 and 3, and then go into the 9. So the questions, the first two questions here would compromise the PHQ-2. How often have you been bothered by each of the following symptoms during the past 2 weeks? Feeling down, depressed, irritable, or hopeless? And the answer choices for all three questions are not at all, several days, more than half the days, or nearly every day. Question 2, little interest or pleasure in doing things. And for the PHQ-3, you add the following question, which again is question 9 of the full PHQ-9. Thoughts that you would be better off dead or of hurting yourself in some way. So if the adolescent screens positive for depression with the PHQ-2, then you would go on and ask the full PHQ-9A. When asking the PHQ-3, if that last question about suicide risk is answered positively, you would administer the Columbia Suicide Severity Rating Scale, commonly referred to as the C-SSRS or even the Columbia Screener, or the Ask Suicide Screening Questions, or the ASQ, which is the Columbia Screen is they have versions for adolescents as well as adults, so it's commonly used for both adolescents and adults, and the ASQ is specifically for adolescents. We will go over the Columbia Screen during this webinar. At the ASQ, we will not, but there are some information in the slides about it, and you can access it. It's readily available online. So when using the PHQ-2 or the PHQ-3, you would then just administer the remaining 7 items. So you don't have to then restart the PHQ-9. You just start at question 3. So the full PHQ-9. So we're just, like I said, we're going to start from question 3. How often have you been bothered by each of the following symptoms during the past 2 weeks? And again, the answer choices are the same: not at all, several days, more than half the days, or nearly every day. And you would provide those responses to the adolescent when conducting this. So the question 3, trouble falling asleep, staying asleep, or sleeping too much? Poor appetite, weight loss, or overeating? Feeling tired or having little energy? Feeling bad about yourself, or feeling that you are a failure or that you have let yourself or your family down? Trouble concentrating on things like schoolwork, reading, or watching TV? Moving or speaking so slowly that other people could have noticed? Or the opposite, being so fidgety or restless that you were moving around a lot more than usual? And then again, the last question, question 9, thoughts that you would be better off dead or of hurting yourself in some way. Now, to score or interpret the PHQ-2, the 2 questions each have the same 5 answer choices. They equate to a certain number. So answering not at all would be 0 points. Several days, 1. More than half the days, 2. And nearly every day, 3. So if an adolescent scores a 2 or 3 to either question, that's considered a positive screen, and then would solicit the rest of the screening tool of the PHQ-9 to further assess for depression. If the answer's 0 or 1 to both questions, it's a negative screen. So there's no further assessment for depression necessary. The scoring structure for the PHQ-9A is the same. So you just add the total amount of points for all 9 questions, and then a score of 10 or greater is considered positive for depression, and that further diagnostic evaluation for major depressive disorder should be done according to the DSM-5. So the scores align here, and they really explain the severity of the depression. So if a score of 0 to 4 is no depression, a score of 5 to 9 means indeterminate or mild depression. So this means that typically an adolescent could have had a major depression and it's now improved, or it could be chronic mild depression, which is called dysthymia, or transient mild depression. So this tool can't distinguish among these. So it's really, if an adolescent does score in this range, clinical judgment should be used to determine the appropriate next steps as to whether you think the adolescent needs further assessment or there is no further assessment warranted. A score of 10 to 14 indicates moderate major depression. So this is when we start to get into the positive category. A score of 15 to 19 is moderately severe major depression, and 20 to 27 is severe major depression. All right, so now we're going to get into the Columbia screening tool, the C-SSRS. And remember that typically when, if you're conducting SBIRT, which is the purpose that we're all on this webinar for, that we're looking at more universal screening. So we wouldn't necessarily universally screen using the Columbia, but we would use the PHQ-3. So if an adolescent is indicating that they have a wish to be dead, which is a passive question regarding suicide risk, that you would want to conduct a further screening that can really more closely identify the level of risk. And that is what the Columbia does. So just to provide some basic information. So there's a big risk, an interconnection between substance use and suicide. Suicide is the second leading cause of death among youth and young adults aged 10 to 34. What is I'm constantly reading about in the newspapers is the rise in suicide recently among youth as compared to other age categories. And this is, though we do know that actual suicide, the rate of suicide among youth is lower than other age groups. We know that the self-harm rate is higher, and that this suicide rate has been increasing at a rate faster than any other age category, which is very troubling. We also know that across the nation, suicide in general has been increasing, while other issues related to public health and funding and interventions have been decreasing. And the suicide rate has been increasing along with opioid overdoses, which are also closely connected. So this is something, the intersection of substance use and suicide, which is very important to address. So the substance use is the second most common risk factor for suicide behind depression. And actually, studies show that alcohol misuse increases risk tenfold, and drug use 14-fold. So this just underscores how critical it is to screen for suicide risk in addition to alcohol and other drug misuse. And before we get into the actual Columbia screening tool, there are many similarities in a suicide safer care protocol in a medical setting as to the SBIRT model. So we're going to go over the screening tool, but there are also there's an evidence-based brief intervention which could be conducted, as well as protocols for follow-up and monitoring, very similar, and referral, very similar to the SBIRT model. So as I was saying, this Columbia Suicide Severity Rating Scale, it's commonly referred to as the C-SSRS or the Columbia Screen. It's a 6-item scale, and it assesses risk among adolescents with depression, and it really covers, it's not, unfortunately, not sufficient to only ask that last question of the PHQ-9 about that passive suicidal ideation about wishing to be dead. This gets the full range of ideation and behavior, including intensity, frequency, and changes over time. There are many versions available at the Columbia Lighthouse Project website. They assess for lifetime and recent behavior, as well as an initial visit versus a since last visit version. It's available in many languages, actually over 100, and it's validated and evidence-based for use with people of all ages in any setting. So all items on the tool are yes/no questions. The first two questions assess general ideation. So again, this is the first question is passive ideation, or the wish to be dead. And the second question is active ideation, or having any thoughts of killing oneself. A yes response to any thoughts of killing oneself triggers the remainder of the questions. So the remainder of the questions get much more specific and really identify how high the risk level actually is. Um, because I will say it's very important to provide intervention and treatment in the least restrictive environment. So a lot of times, if we don't have familiarity or feel comfortable talking about suicide or addressing suicide risk, even saying that identifying passive ideation or the wish to be dead could be very alarming to you as a practitioner, and you may, you might not be sure what to do. Um, Unfortunately, there may be a certain number of actual suicides, but it's exponential of people that we talk. So for every person that dies by suicide, there are 25 suicide attempts that are non-lethal, and then an exponential number of people who are thinking about suicide or have been touched by suicide. So we need to assess how high a level of risk, and that really depends on the presence of a plan, intent upon acting on thoughts, and having a plan and intent on carrying out the plan. And then, of course, actual suicidal behavior, both lifetime and recent. So suicidal behavior, not only making a suicide attempt, but also could be an aborted attempt when you were planning to do something and started to do it but got interrupted. So this is the C-SSRS highlighted with kind of providing the meaning of answering to yeses to specific questions, and then what that means. So the first question is, have you wished you were dead or wished you could go to sleep and not wake up? And this is the past month version. So you get getting those responses in the past month. So this is as I said before, the passive question. And then the next question, have you actually had any thoughts about killing yourself? So this is the active ideation. So there's actually a pretty big difference between endorsing passive ideation versus active ideation. So if answering yes to 2, you go on and ask the rest of the tool. If the answer is no to 2, you go on and ask about question 6. So always ask question 6. So question 3 is asking about method. Have you thought about how you might do this? Because if an individual has given some thought and has a method plan, that's a higher risk. Have you ever had any intention of acting on these thoughts of killing yourself, as opposed to you would have the thoughts, but you definitely would not act on them? So this is intent. So if you actually intend upon acting on these thoughts, it also indicates a higher risk. In this case, high risk. Question 5, have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? So this is getting at both plan and intent. And then the last question, question 6, have you done anything, started to do anything, or prepared to do anything to end your life? So this is assessing for past suicidal behavior. And this is in the past 3 months. So you could see, the light yellow is the low risk, the orange is moderate risk, and the red is high risk. Okay, so what does it all mean? So low risk. So you would say a yes to question 1, or question 1 and question 2 only. This means that the individual has ideation but no plan or intent. So it would be the action would be to provide a behavioral health referral. The medium risk is a yes to question 3. That means there's ideation as well as a plan, but no intent to actually act upon that plan. So the action would be to provide bring in a behavioral health consult with a psychiatric nurse or social worker, and to consider safety precautions. high risk is yes to questions 4, 5, or 6. That means that the individual has ideation with either intent only, intent and plan, or recent suicidal behavior. And then the action would be a behavioral health consult and patient safety precautions. And now I'm going to hand it back over to Ken.
Thank you, Brett. There are just a few additional screening tools to note. And they are summarized here. And then we have a resource to point you to. NIAAA has developed its own tool called the NIAAA Youth Screening Guide. It's, of course, just alcohol only, but it does a nice job of screening for frequency and quantity of alcohol use. Similar to the BSTAD, it also has a set of questions about peer alcohol use, and its scoring guidelines are anchored with that domain in mind. So a young person who hasn't used alcohol yet but is affiliating with friends who do, that would put that teenager in a recommended for brief intervention category. The NIDA Quick Screen is appropriate for young adults, age 18 and older. It focuses on past year frequency of use of multiple substance categories. If you're interested in adding an opioid screening tool to your toolbox, there's the Clinical Opiate Withdrawal Scale. This is a brief screen that intends to examine the level of physical dependence on opioids by focusing on possible signs of withdrawal. Then I want to point you to the resource by NIAAA. It's a comprehensive screening handbook, and among many of its chapters, one of them, Chapter 5, focuses on adolescent screening and assessment methods. Has a lot of detail, a lot of references, and provides some sample items as well. So I want to thank everybody for their attendance, for providing an opportunity for us to give an overview of screening processes and screening tools. And hopefully you'll take advantage of the additional webinars that delve deeply into the brief intervention referral to treatment components.
Well, thank you, Dr. Winters and Dr. Harris. We appreciate you sharing your expertise with us today and for your detailed review of some of the most widely accepted tools, including some of the most recent screening tools and updated versions that are important for us to think about how we can integrate these tools into our work. One thing that I would mention about the tools is that, as you can see, there are a number of different tools to choose from. And you can think about how do these tools really fit in your setting, which fit best with kind of the workflows, staff, your goals for your SBIRT implementation, and think about which of these might work best for you. Also thinking about looking at your current screening tools and, are those validated tools? Might one of the tools we've talked about today replace existing tools that you're using if those aren't validated, or maybe you like some of these because they're more brief, or they touch on multiple substances, or they touch on nicotine or vaping specifically. So lots of choices, lots to think about, but it's nice to have a menu of options. One of the things that I would also mention about the tools is that we have had a really nice detailed review of these, and there are also some additional tools in the Learner's Guide to Adolescent SBIRT that we talked about earlier. And as we do about the tools that we've discussed today, we also include information about tools that Dr. Winters mentioned at the end, just some additional examples, including, how to score them, how to administer them. We provide the age-appropriate population for each tool, the mode of administration, how can you access it. We try to provide as many publicly available tools as possible. And we also include in the Learner's Guide copies of those tools, which we have permission to do in the appendix. And in addition to that, we include additional role plays for each of the screening tools that are included, as well as those sample interactions, scripted interactions that can be used either as part of a training or education that you're providing in an academic institution. So all of the tools here are available to you to integrate in any way that you would like into the work that you're doing. You can use this training and this series as a standalone training resource. You can also combine it with the Adolescent SBIRT Learner's Guide and all of the complementary slides that come with the Learner's Guide. Those are all available to you, at no cost. So I'll just remind you that the website to get all of that information is sbirt.webs.com. And the Learner's Guide specifically is on the website where you can request it by going to sbirt.webs.com/curriculum. In our last few moments together, I want to remind you of a couple of important things. First, you can access the PowerPoint slides from today's session, as well as related materials and resources on the website dedicated to this webinar at sbirt.webs.com/substance-screening-tools. In addition, you'll also be able to access the on-demand 24/7 and where you'll find additional information about the certificate of attendance. I'd also just like to remind you that the follow-up email that you will receive after our session today will point you to a variety of resources that I just shared with you, and also will ask you to complete a short evaluation survey that'll really help us to understand better your needs and to be able to really bring you additional professional education that you're most interested in. If you have any questions about screening, brief intervention, referral to treatment, implementation, evaluation, training, the curriculum, information shared with you today, and you'd like some guidance or advice about that, you're welcome to email me at mcpherson-tracy@norc.org, and we can schedule a free telephonic technical assistance session. You're also welcome to email me questions. We can, exchange information that way. So please take advantage of this resource. And finally, I just want to thank you all for attending and thank Dr. Winters and Dr. Harris for their expertise today. And I hope everyone has a great rest of the day. Thank you again for being with us.